Hey everyone. So I wanted to talk to you all about the clinical trial that I had chosen. The clinical trial identifier, the name for the trial is called NCT 000-20566. Um, nice long name for you. It's kind of difficult to remember. Um, this was a trial. The phase started in 2001. It's a phase 3 trial, which all of us have learned. There's kind of a higher volume of patients. Usually over 1,000 patients are included in these trials. And for this case, they try to determine a better way to treat Ewing sarcoma, which kind of, as some of you may or may not know, is kind of a difficult case to treat using radiation. It is a little bit radiosensitive. So for this case, I mean, part of the reason I chose this case, interestingly enough, is I actually had a friend just a few years ago go through this trial. Um, One of my dear friends, I was able to talk to her a little bit about it and kind of to figure out, what it was like being a patient in it. Um, she's not doing the greatest right now, but ultimately she's happy she went through this trial, and her main reasoning behind it was so she could help future cases, with her kind of cancer and her Ewing sarcoma diagnosis. So um, this the details to this were basically to compare the control group, which was your standard chemotherapy regimen for Ewing sarcoma, and then they wanted to compare it with concurrent radiation therapy as well as high levels of chemotherapy and see kind of the toxicity and see what the organs could take and what they couldn't. So this was a worldwide study. And they actually expected to have approximately 1,200 patients when it was all said and done. Like I said, it was a phase 3 trial, so obviously it was over 1,000 patients, somewhere between 1,000 and 3,000. So 1,200 was a good number to expect. Um, the trial itself actually consisted of two separate groups. The second group had two arms, and then the first group just had it was just simply that. It was just one group. Um, 10 sponsors actually combined to do this trial, which was interesting. I don't know how often we see that. But some of the main ones were NCI, the National Cancer Institute, as well as the Children's Oncology Group, and the Children's Cancer and Leukemia Group was another one. So there's 10 sponsors in all, that kind of combined, and we'll share the data with this project. These sponsors that were conducting the study, they were worldwide sponsors. Like I said, it happened around the world, all these trials, but 90% of them did happen in the United States. In total, actually, there was 104 sites um, that that had took part in this clinical trial. Um, but like I said, even though there were 1,200 patients that they were expecting, not everyone's going to be eligible for this. They kind of had to pick and choose. And for starters, you had to have cancer in the Ewing family, whether that was extrapulmonary or a pleural metastasis or something like that. The cancer had to be in the Ewing family. Also, they needed to be under 50 years of age, which typically isn't a problem because Ewing sarcoma happens in younger adults, teenagers, something along those lines. So probably not usually a problem, but they did have to be under 50 years of age. It also had to be within 45 days of a definitive biopsy, which they wanted something recent, something that had been growing for a while, something where they haven't had a lot of treatment previously. But if that is the case, there was a couple other different things about it. Um, the tumor could have been resected, but it had to be less than 200 milliliters at the time being. Or if it was an unresectable tumor or a metastasis or something like that, if it was greater than 200 milliliters, uh, it needed to have be able to be controlled by radiation therapy. So those are kind of the things that they were looking for to include and exclude patients from this trial. So as I previously had talked about a little bit, there are two possible groups for this trial. The first one kind of assigned the patients. It wasn't randomized, just to assign them between one of the two groups. And then if they were placed into the second group, it was randomized into two separate arms. So it's kind of an interesting case in that they both assigned them and randomized the patients all in one. Um, so it was interesting that all the patients started with the exact same treatment. Um, so the first day was just simply chemo. It was just simply 1 day of vincristine, I believe, is what it was. Um, so it was just that, and then the following 3 days were also ifosfamide, doxorubicin, and topicin, I believe. And they did that exact same course every 3 weeks for 6 courses. So every patient in this trial did that treatment. Um, However, if the patient, as we see in a lot of Ewing sarcoma patients, if they end up with, a brain metastasis or a spinal cord metastasis or something, they were allowed to get radiation therapy immediately. Um, so if they did need brain radiation or spinal cord radiation, craniospinal radiation, they were automatically entered into group one. So that was what I was talking about earlier, where they were either assigned and then randomized. So they're assigned based on if they needed radiation therapy right away to the brain or the spinal cord. Um, so if they were entered into group one, uh, there were eight courses additional with that first 6 courses of chemotherapy. So another 8 courses of the chemotherapy regimen, plus they received the radiation to the brain or spinal cord or whatever it was that they needed their radiation on. And I'll go into the radiation portion of it a little bit later in the presentation here. The second group actually has, like I said, there were 2 arms, 2 separate arms, and they were randomized into that. One was a little bit more aggressive than the other. And arm one, again, received 8 additional courses of chemotherapy. Plus, they received whole lung radiation therapy, which, again, I'll explain a little bit later. And then group two, arm two, was a little bit more aggressive with their treatment. They again received 8 doses of chemotherapy, but it was a higher intensity, higher dose regimen. And that actually only was 6 days. Plus, they also received the concurrent radiotherapy in that arm. So the radiation itself was very dependent on the site. Obviously, Ewing sarcoma is one of those things where it could occur just about anywhere. So you can't specify the clinical trial as just to the brain or just to the cord or just to the lung or wherever it may occur. So that made things a little bit more difficult for them, I'm sure. Like I said, it's a little bit dependent on the site. And then the radiation also depended on the group, like I said, and what arm of group two they would be in. So group one, both the brain and the spinal cord received your standard palliative doses, which some places may vary, but it's pretty well thought out that they do 30 gray in 3 gray fractions times 10 fractions. That's basically the standard. So they did that for both brain and for craniospinal radiation. So they did it just like they would any other whole brain or something like that. And then group one, like I said, like I'm talking about the radiation in general now. For the whole brain, they would just do 2 laterals. They wouldn't kick the collimator. I know some places like to kick the collimator to black out the eyes and some of that kind of stuff, but they just did 2 laterals and had blocks put on. So that was kind of the standard for this clinical trial. For the craniospinal radiation, they just did your simple PA field with mapping fields using the gap calcs that we had talked about earlier in the year and stuff. So they just did that as well, and like I said, they did 30 gray 30 gray, and 10 fractions. So um, this occurred typically over 2 weeks, 2 week period of time. Group 2, arm 1, like I said, there are 2 arms in this. So group 2, arm 1, received concurrent radiotherapy. Uh, this meant APPA, usually to whatever treatment region that they were treating, I guess, at the time. Again, it was your standard palliation, 30 gray and 10 fractions. So it's pretty much standard. It just, like I said, because Ewing sarcoma can happen anywhere, it could be, um, it was completely dependent on the site. But most of them were just your typical APPA. Group 2, arm 2, is a little bit more vague again. It treated more extra pulmonary tumors. Um, this was 45 gray, however, in 25 fractions over 5 weeks. So this was a lot more elongated. Again, it was concurrent with the chemotherapy as well, but this radiation was a lot more elongated, and the chemotherapy was more aggressive. So that was kind of the difference between group 2, arm 1, and group 2, arm 2. Um, so as far as the follow-ups go and kind of collecting the data and stuff, because obviously that's one of the most important parts for a clinical trial. So the follow-up for this, they did follow-up with patients every 3 months for 40 years, which seems like a lot, but it's good to be collecting data that often. And then the 5th year, they did it biannually, so they did twice every 6 months for the 5th year. And then from there on out, it's just periodically after that, no real set time. So that was kind of the follow-up, and they made sure to test for toxicity and feasibility and things of that nature. Check the response, see how the tumor is responding, and these are all things that are characteristic of any phase 3 trial. Just to see how some of the organs are responding based on higher doses, and see if it really is a possibility to be used in the future. And then finally, I wanted to talk a little bit about the benefits of doing this clinical trial, just to the patients and to the organization and all of that. You know, Truthfully, when you're going into one of these clinical trials as a patient, you don't know if you're gonna receive, which group you're gonna be in, and you don't know if it's gonna help you or not. It's kind of a shot in the dark, and you know, it may go ahead and help you, and that might be one of the benefits to doing a clinical trial, because they just don't know without these trials what to expect. So, that's one of the benefits anyway. As far as the sponsors go, they get the benefit because they technically own the rights and the data. If they want to publish these findings or not, it's kind of up to them. So they're going to be getting some money out of it, obviously. um, you know, but it's a great thing to have. And then finally, like I said when I was talking to my friend, you know, the main benefit to doing these clinical trials is to help future generations, especially in cases like this where most of the treatments are palliative treatments, and you just kind of might be a last-ditch effort, but at the same time, you're looking to help out future generations that have this disease. So, sometimes it seems like a very selfless act to be a part of these clinical trials, but it's really the only way that we're going to help our future generations. So, um, well, I very much appreciate you guys, you know, hearing my presentation and listening through this. Like I said, I know it was kind of a strange case, as it was very specific and it wasn't about one group or something, but it held dear to me as one of my friends played a part in this. So thank you again for your time, and I hope you guys have a good rest of your day. Take care. Thanks.